Good evening, everyone. Today we'll be discussing corneal graft rejection, and I'm Anjori Gupta. I'll be presenting the class, and the moderator for today's class is Dr. Meena ma'am. So we'll be discussing few cases, and after that we'll be discussing of what actually graft rejection is. So starting with the first case, 37 years old male complains of sudden painless diminution of vision in the right eye for the last 3 months. He was a known case of both eyes congenital hereditary endothelial dystrophy. The right eye had multiple, like 2 times PK was done, and the last PK was done 3 years back. Left eye also 2 times PK was done, and the last PK was done 21 years ago, which had a failed graft. Right now, the patient is on right eye dexamethasone eye drops 2 times daily, with timolol eye drops twice daily, and refresh tears, which is 4 times daily.
I told you to change all that, right? Don't write commercial names.
Refresh tears, yes.
I had to sit and change all your things. So what is it? What is the composition of refresh tears?
Ma'am, carboxymethyl cellulose.
Yeah, so you have to write carboxymethyl cellulose.
So the best corrected visual acuity was counting fingers at 1 meter. Here we can see that the graft is centered. The sutures are well intact with corneal vascularization in 3 quadrants. And patient had a IOL removal, so the patient has aphakia, and there is a central infiltrate of 4 into 4 millimeters. So a corneal scraping was done, and it was it came positive for gram-positive bacilli. So the patient was started on azithromycin eye ointment twice daily with loteprednolol eye drops 8 times daily, tapering dose. So 3 months after, the best corrected visual acuity was counting fingers 1 meter, where the infiltrate had healed, sutures were intact, but the cornea had become more hazy, and there was deep corneal vascularization. So the patient was diagnosed to have a failed graft. So the patient was planned for re-PK and was started on prednisolone eye drops 10 times daily, tapering dose, with homide eye drops twice daily, moxifloxacin eye drops 6 times daily, and timolol eye drops twice daily, with oral prednisolone 60 mg tapering, as it was a high-risk keratoplasty. So on the post-op day 1, the graft was clear with graft host junction secure and all sutures intact. The patient was kept on prednisolone 10 times tapering with oral prednisolone 40-30 tapering dose weekly, and also tablet mycophenolate mofetil 500 mg twice daily, and moxifloxacin eye drop 6 times daily. At 1 month post-op, the best corrected visual acuity was 2/60. The sutures were intact. The graft had multiple deposition of cells which were coming from the periphery to the center, forming a undulated elevated line. So this line is basically a sign of epithelial rejection line. And so the patient was kept on the similar prednisolone eye drops 10 times daily with oral prednisolone and
what was the despite our maximum immunosuppression, mycophenolate, tablet prednisolone, drops, oral vizolone, why do you think this occurred? What should your first what should you think about if he is developing a rejection line despite maximum immunosuppression?
Ma'am, basically he had a previous, it was a high keratoplasty, like high-risk keratoplasty, because he had multiple PKs done.
You saw the file, right?
Yes,
this patient had a history of poor compliance.
Yes, ma'am. Yes, ma'am.
So the first thing that you need to ask if the patient develops a rejection line like this is whether he is taking his oral medications.
Yes, ma'am. He was on medicine at this point, ma'am. When he came to us,
he might say, but what did you have to do? You have to physically check. Okay, none of you do it. None of you physically check medications at all. So they will be using refresh tears only, because that is probably the easiest for them, and they'll use it 4-5 times. He must have not been using steroids because he was probably taking one of those tablets. He didn't develop an endothelial rejection. Yes, he developed only an epithelial rejection. Yes, probably this epithelial rejection means that topical prednisolone was not going on. So that endothelial rejection didn't take place, but epithelial rejection took place. Okay. So what happens in epithelial rejection? What is fighting against what?
Basically there is there is accumulation of the NK cells, the lymphocytes, the MHC on the epithelium.
No, which is now, which, what is getting rejected here? By now, epithelialization should have fully occurred.
Yes, ma'am.
Which epithelium should have fully covered the cornea?
Like the host epithelium will come over the
So this
donor,
means
yes,
that actually he has completely epithelialized.
Yes, ma'am.
Only in an epithelialized graft a rejection can take place like this. If there was persistent, this is not a persistent epithelial defect.
No, ma'am.
So commonly when this patient was seen by the cornea fellow, they thought it was a epithelial defect.
Yes,
so the first thing that they did was to put fluorescein. But is it a fluorescein taking stain?
Ma'am, it actually is fluorescein and rose Bengal
Rose
staining.
Bengal taking stain. So it actually means that in a month, the epithelium was completely of the host.
Yes.
That's why the rejection took place, and not an endothelial, because oral medications might be going on, but the topical medications were not going on.
Okay.
So all of you should check medications. You cannot assume that the patient is using.
So the patient was kept on topical prednisolone, oral prednisolone, and oral mycophenolate mofetil. So at 2 months post-op, the best corrected visual acuity was 3/60 with a pinhole vision of 6/60. And we can see clearly that the graft has cleared fully with sutures intact and a centered graft. The IOP was measured as 12. So the patient was called after 3 months. So coming to case number 2. A 34-year-old male complains of right eye gradual painless blurring of vision for the last 2 months. He was a soft contact lens user for the last 10 years. He used monthly disposable lenses and was following a good hygiene practices. There was no history of trauma or surgery in the past and nil systemic illnesses. He was treated for acanthamoeba keratitis for 9 months in our hospital and was on right eye polyhexamethylbiguanides eye drops 1 hourly with chlorhexidine eye drops hourly and homide eye drops twice daily with tablet indomethacin SR 75 mg twice daily. The best corrected visual acuity was...
It is always once, it's not twice. There's some mistakes. If you give endomethacin twice daily, they'll die. They'll get a perforation. It's once.
Okay.
It's sustained release. That's why it's only once.
Okay, fine. The best corrected visual acuity was noted as hand movements. So here we can see under slit lamp examination in diffuse illumination that there is a total corneal adherent leukomatous scar with superficial vascularization. So the patient underwent a right eye penetrating keratoplasty.
So that is a sign of a hypertrophied epithelium, full thickness corneal scar with over, you should say this is a full thickness corneal scar seen on probably, this is in the diffuse illumination, this appears to be a dense scar involving 3/4 of the cornea. The elevated epithelium gives a clue that this could be a hypertrophied epithelium. And hypertrophied epithelium has this typical keloid-like features. Can you see that?
Yes, ma'am.
Dense white, pearly white. That is the definition what they say. This is having probably this is a secondary keloid actually.
Okay.
You can't see deep vessels. You can see superficial vessels in this.
So the patient underwent right eye penetrating keratoplasty. On post-op day 1, the graft host junction was secured with DM folds on the cornea and sutures were intact. And the finger tension was okay. The patient was kept on prednisolone eye drops 10 times daily, tapering weekly, and oral prednisolone starting from 50 mg, 40 and tapering weekly dose. On 2 months post-op, his best corrected visual acuity came to 6/6 with 1 diopter spherical and -3 cylinder at 180 degrees. Here we can see that the graft is a little on the eccentric side, but the sutures are absolutely intact with the clear graft. And the pachymetry and the specular microscopy also shows that the endothelial cell count is within normal limits. At 5 months post-op, the patient complains of sudden diminution of vision since the last 2 days with redness, and he gave a history that he was not putting any topicals. The best corrected visual acuity came down to 6/36, and here we can see a graft which is hazy, along with the multiple nummular opacities which are subepithelial, along with a mild edema here. We can see in the slit. And so the patient was diagnosed.
Also, I told you something to tell about the
Yes, ma'am.
conjunctiva
Yes,
and
ma'am.
bulbar. What
Ma'am,
should you
the
say?
patient has conjunctival injection with superficial vascularization, and the superior graft is a little clear in comparison to the inferior graft, but otherwise, yes, ma'am.
So, what was the difference in the way both these patients presented? What do you think? How did the first patient present, and what did the second patient present? What is the difference?
Ma'am, this was more sudden, I would say.
No,
And,
he presented without a what do you say? What do you call that? Appointment. He came to the emergency.
Yes, ma'am.
Whereas the other patient didn't come to the
Yes,
emergency.
yes,
he came for a routine
Yes,
checkup.
ma'am. Yes, ma'am.
So that's how silent epithelial rejection is. And that's how subepithelial, whatever you're going to say now, the
Yes,
difference is. So this is a more
Emergency,
subacute
like
presenting. It's not like a real emergency, but he came on his own that he's not feeling okay, what he was enjoying the vision. So that's very important. When your best corrected vision in a graft, a patient says that has fallen, it is an emergency.
Yes, ma'am. So the patient was diagnosed to have subepithelial rejection and was started on right eye prednisolone 1% eye drops, 1 hourly tapering weekly, and was called after 3 weeks.
So any cornea fellows, can you say any differential diagnosis for this condition? How was the other eye?
Ma'am, the other eye, this patient was...
No, did that have any redness,
no,
pain?
No, this was a normal. No, ma'am.
So you have to say it is a unilateral
Yes,
at
ma'am,
this
unilateral. Yes,
thing.
ma'am. Yes, ma'am.
Any cornea fellow present? Madangi is there?
Ma'am, it could be SPK secondary to secondary conjunctivitis.
Very good. That's a very good differential, because yes, that probably is more common in both grafted and non-grafted. But why is it not? Why so many patients come to us after their acute conjunctivitis episodes are over and they come like this with SPKs? So if I tell you that what are the points against this being a...
It is only involving the donor cornea.
Very good.
Graft,
So
and not involving the host.
So if you see, if the rest of you can see what Madangi is telling, that the peripheral cornea is clear. If this were really be adenoviral keratoconjunctivitis sequelae, so these infiltrates should also be in the periphery.
Yes.
And what other things are not there? Differentials. So conjunctiva, you should look for what?
Follicles.
Ma'am, any discharge follicles. Or
Yes,
papilla.
these are very basic.
Yes.
So you will tell
Yes.
that the conjunctiva, there was no signs of
inf-
conjunctivitis like old follicles, or you can't say papillae, or you have to tell that there was a negative history of family members being involved, because that's a very positive finding that it was
Yes, ma'am.
adenoviral keratoconjunctivitis, painful or painless lymphadenopathy,
Yes,
and matting of the lids. Prior history was asked and was noted to be negative. So this has to be asked. Okay.
Yes, ma'am.
So this is very rare. Only if you know how to identify subepithelial, you can identify subepithelial. These are really very, very rare findings. I've probably seen only 4 in so many years.
So the patient was called after 3 weeks, but unfortunately the patient was lost to follow-up and came after 5 months post-op. He was on prednisolone 1% eye drops 2 times daily. His best corrected visual acuity was fortunately 6/12, and the graft had cleared with sutures intact, and the IOP was within normal limits. The pachymetry and the specular microscopy showed that the endothelial count was also within normal limits. So coming to case number 3, a 24-year-old female came with left eye diminution of vision for the last 2 years following alleged history of a trauma while performing martial arts, and has been worsening since then. The best corrected visual acuity was perception of light present with perception of rays was accurate. On slit lamp examination under diffuse illumination, we can see a total corneal opacity which is vascularized with superficial and deep vascularization. And the IOP documented was 32 millimeters of mercury. So the patient was started on timolol eye drops twice daily. The ultrasound was within normal limits, and the UBM also showed absorbed lens matter. So the patient underwent left eye penetrating keratoplasty with lensectomy and vitrectomy, along with scleral fixated IOL under general anesthesia and guarded visual prognosis. So on
seeing all this, can anybody say what are the why this patient and how you should counsel, and what are the risk factors versus somebody who's 70 years? How will you counsel them? Anybody, please answer. It's okay, just take a shot.
Ma'am, especially in younger patients, the chance of resection is more than
Very good. So you have taken a young patient to operate. So she becomes a patient lifelong in your OPD, right? So that's very good. That's the first thing you will see. You have taken a young patient. Second, what are the other problems in this patient? How do you see that the graft will look like when you operate? It's a very large graft. So you can't take a 6.5 or a 7 millimeter. You can still take, but yeah. So this is a large graft. Then what else? What are the other risk factors? Vascularization. Something about the history, trauma. So there was a history of trauma. Very good. Then what are the other, one more problem written there? Two more problems there. Raised IOP. So we have so many factors not to operate her. But I think she was very persistent for surgery, and the surgery was not my surgery. Mine, I've only done, or anybody? Way back. Yes, okay. So, what is the other problem in her? What is the other risk factor in this patient? You've answered everything. All of you are brilliant. One more. Look at the surgery. PK, lensectomy, vitrectomy, SFIOL, more of manipulation, right? The eye is not left alone. You're digging deep into, and we have put an SFIOL and all that. That means more vigilance is needed. So, in all these three cases, what was the common factor for our patients to have this problems? What was the commonest factor among these three?
Vascularization.
Young patients. All of them were young, right? So, the younger the patients, the more chances of rejection. So, that's why I think we don't have any patient who's old. All of them were young. All your three patients are young. Okay.
So on post-op day 1, there was one epi defect. Other than that, the graft was centered with sutures intact. The patient was lost to follow-up, and after 1 year, he complains of left eye sudden redness with watering and diminution of vision since the last 4 days. He gave a history of stopping dexamethasone eye drops, and he was using timolol twice daily, which he had used 4 days back, and also moxifloxacin eye drops 3 times daily. The best corrected visual acuity was noted as counting fingers at 50 centimeters. So here we can see under slit lamp examination in diffuse illumination that the graft is well centered, the sutures are intact, but the superior part of the graft is much clearer in comparison to the inferior graft. We can see around 360 degree superior vascularization and at least more than 2 quadrants of deep vascularization. The IOP was also noted to be in higher range of 21, 20, 24.
And does this blood vessels look recent or do they look old?
Ma'am, recent, ma'am.
Recent. So this looks like sudden congestion, yes, right? Yes, you can follow them right into the bulbar conjunctiva. Otherwise, if the graft has superficial blood vessel, in between the superficial blood vessel, there will be clear areas. Yes. But here, the entire superior bulbar conjunctiva is so angry, and blood vessels are going up, reaching up to the graft.
So the patient was diagnosed to have left eye failed graft or graft rejection due to poor compliance. He was started on left eye prednisolone eye drops 8 times daily, tapering weekly, along with sodium chloride eye drops 6 times daily, along with sodium chloride eye ointment once at night, and timolol in view of high IOP measured.
Yeah. So sodium chloride, I don't think I would have given 6 times. The maximum I give is 2 times. There's something wrong there. We'll correct it later.
Yes,
we'll probably printed it and then corrected it. So there's no point in giving anybody 6 times. That will kill the epithelium. Yeah.
So the patient was explained about the good need for good compliance to eye drops and was called after a month. So coming to the next case, a 53-year-old male complains of left eye redness and pain since 1 month. He gives a history of both eyes cataract surgery done elsewhere 7 years ago, and there was no significant improvement of the vision post-surgery. The right eye had a penetrating keratoplasty done 6 years ago, while we didn't have any reports available. Left eye also had penetrating keratoplasty done twice, and the last PK was done with IOL removal 2 years back. As of now, the patient was on left eye prednisolone eye drops 1 time daily, along with carboxymethylcellulose eye drops 2 times daily. And the patient had a history of using anti-glaucoma medicines before, but as of now, he was not using any medicines, and he was a diabetic and hypertensive on medicine. So on slit lamp examination under diffuse illumination, we can see a graft which is involved with a total infiltrate with an overlying defect. There were loose sutures present on the temporal side, and FT was on the soft side. So the patient was planned for left eye penetrating keratoplasty. On post-op day 1, the graft was clear with graft host junction secure and sutures intact. There was a resolving heme, and the FT was firm. The patient was kept on dexamethasone eye drops 10 times daily, tapering, and was called after review after 1 month. After 1 month, the patient was on dexamethasone eye drops twice daily. The best corrected visual acuity was counting fingers at 1 meters. So here we can see there's one loose suture on the temporal side. Other than that, all sutures are intact. But inferiorly, we can see multiple small KPs, keratic precipitates on the endothelium, which is coming from the periphery with endothelial edema over it. So this is a sign of endothelial rejection. Can somebody tell what is it called? So on ASOCT also, we can see the same Corrados line, which is here, multiple KPs are there on the endothelium. And on pachymetry and specular count, we can see there is endothelial cell loss. So the patient was started on prednisolone eye drops 10 times daily, tapering dose weekly, and was called for review after 3 months.
So between the first case and second case, what are the what are the one extra cause of worry? If you remember what you presented in the first case.
Ma'am, first case, the epithelial rejection, yes, ma'am.
Did that patient also had a...
Yes, ma'am, in the first visit.
So, no, did it have a bilateral problem?
Yes, ma'am, both eyes. Yes,
so, a patient who's having an antigenic source, alloantigen from in the other eye also, is also a chance of rejection. Okay. So, as a rule, so whenever we do corneal transplant in the eye, in one eye, which has a bilateral condition, and you have performed another corneal penetrating, that of full thickness graft, you always hike up the steroids in the other eye when you operate freshly on the on one eye. So that is the antigenic systemic antigens that can it can cause an immune rejection of the other eye. So remember that. So when you work anywhere in the world, when a patient has had fresh corneal transplant, the other eye also you need to ask if you have to increase, especially if there are sutures. If there are no sutures, maybe not, but if there are sutures, yes, you will have to hike up the steroids. So in all these presentations, you need to have seen the file if we gave another prescription for the other eye. So I don't think that information you would have seen.
Ma'am, this patient we didn't give for the other eye, but that first
patient... If it is completely failed, okay, we don't give.
That first patient had a failed graft itself.
Yeah, so we don't give. But if it was a clear graft, we need to give. Otherwise, you'll end up like this.
Yes, ma'am. So coming to case number 5. 60.
How many days after rejection did the patient present? Now that's important, right?
Ma'am, 1 month basically. Like he had...
He just came, but you had to note in the file whether he had any...
Ma'am, he didn't have any symptoms.
This was, so he did not come in an acute case.
No,
because I think some amount of steroids have helped.
Yes, ma'am, he was on dexamethasone.
Dexamethasone. So otherwise there will be acute presentation. So, but this, despite, that's what I'm trying to tell all of you, that despite you giving steroids, there are rejections. So that is why you need to counsel the patient under time. So how is this line described? From where to where is it going? It's spreading across the entire lower cornea. Especially they start around a blood vessel, graft host junction, and they proceed.
Yes.
So especially where they start, that area you need to see this suture whether it is loose. So you will put fluorescein and see if there is pooling.
Yes, ma'am. Okay. So coming to case number 5, a 60-year-old female complains of blurred vision in the right eye for 2 months, associated with pain and redness occasionally. She has a history of cataract surgery done elsewhere in both the eyes 5 years back. No history of trauma, headache or vomiting. She's hypertensive on medication. And we didn't have a slit lamp photo. So the findings in the right eye showed that the counting best corrected visual acuity was counting fingers at 3 meters. There was stromal scarring with subepithelial scarring with bullae. So the patient was diagnosed to have pseudophakic bullous keratopathy. The IOP was within normal limits. And ultrasound, the glow was present, but the details were not seen. So the ultrasound was within normal limits. The PACI showed increased of 868 microns. So the patient was planned for right eye DSEC under local anesthesia.
So this patient would go ahead. So she was a pseudophakic bullous keratopathy elsewhere long time ago, not when I was there, and she underwent DSEC by another consultant in 2008.
Yes.
So this is a long-term follow-up. You go to the next slide.
So the patient maintained vision for 11 years. And at 11 years post-op, she complains of blurring of vision since 3 months, and she gave a history of non-compliance with topical medication.
So she, in fact, she withstood that episode where I have done a yak capsulotomy. Post-operatively also, she has withstood that thing.
Ma'am.
So she has had a yak cap also.
Yes, ma'am. Yes, ma'am.
So yak cap, anything is an inflammation.
Okay.
So, so you need to note that.
Yes, ma'am.
So that post-operatively, she did not. She recovered, not post-op. Post-yak cap, there was no rejection episode.
Okay. Yes, ma'am. So on slit lamp examination under diffuse illumination, we can see there is endothelial edema. Along with that,
not endothelial edema, graft edema.
Yes, ma'am. Graft edema with endothelial rejection lines, which is similarly coming from the graft host junction towards the center. So patient was started on prednisolone 1% eye drop 10 times daily, weekly taper, and was called for review after 1 month. So after 1 month, the best corrected visual acuity improved to 6/18, and we can see superior resolving graft edema, and the IOP was within normal limits of 14 millimeters of mercury. The pachymetry was 681, and there was in specular microscopy, we can see endothelial cell loss of 628 square millimeters. So this patient was diagnosed to have early rejection and was started on betnesol neomycin eye drop 6 times daily, tapering dose, and was called after 1 month. Unfortunately, the patient was lost to follow-up, came after 5 years when she complained of gradual diminution of vision since 1 year. She had a history of stopping medication since 2 months. The best corrected visual acuity fell down to 3/60. Under slit lamp examination, we can see disc edema with interface haze and DM folds. The IOP was 12 millimeter of mercury, and the patient was hence diagnosed to have failed Descemet stripping endothelial keratoplasty and was planned for a re-DSEC under LA.
So and was started does any cornea fellow know how much is the endothelial cell loss in post-rejection in full thickness graft? What is the amount of endothelial cell loss?
Coming to case number 6, this is the same case we discussed in as the first case. We just want to highlight the patient had epithelial rejection after the 3rd PK. He had an endothelial rejection line after his first PK, which was done here, and we can see the similar Corrados line coming from the periphery in the superior part of the cornea, and we can see there is a loose suture, as ma'am is mentioned.
So, what lesson you learned from this? Even in his, a rejection is more common in an eye which has had a previous rejection. Yes. So that is the lesson that you learn.
Yes,
whether it is epithelial, endothelial, subepithelial, we ought to be more cautious in a patient who's had a rejection,
Yes, ma'am.
because
The chances
so we have
of-
mentioned all the risk factors so far,
Yes,
that so including the cause. Now you finish this, and all of you will tell, each of you will tell one cause of that you have seen today as a risk factor for rejection. When you complete,
Yes, ma'am.
don't go to the discussion. Yeah.
Yes. Coming to the case number 7, a 57-year-old female complains of gradual painless diminution of vision in both the eyes since 1 year. She had a history of cataract surgery done 8 years ago. There was no history of trauma. The best credit visual acuity was 6/18 with minus 0.5 spherical diopters and plus 1.25 cylinder at 90 degrees, and N6 vision with plus 2.5 diopters of correction. So under the slit lamp examination and diffuse illumination, we can see there is a cornea is
Bilateral pseudophakic
Yes, ma'am. Yes, ma'am.
keratopathy. So this is not a naive eye. It's already been operated.
Yes, ma'am.
Yeah.
The pachymetry was noted to be 556 microns in both the eyes, and in slit lamp examination we can see both eyes diffuse confluent guttae, which are more in the center, and
You're not teaching endothelial. Go ahead.
Okay.
If you say
So,
PBK, we can
yes,
understand.
so
That's
ASO
okay. Keep going.
yes. So 1 year after, the patient was kept on sodium chloride eye drops thrice
so
daily,
not operated,
and
right?
patient was comfortable.
Yeah.
1 year after, she complains of
Further
morning
decrease
diminution of
in vision,
and the
yeah.
guttae had increased. The vision was dropped to
You
6
can
by
see
60.
scarring also in the slit.
Yes. Ma'am. So the patient underwent left eye DMEC. On post-op day 1, the DMEC graft was in place, well attached. The AC was deep and cornea was clear. In ASOCT also we can see the same. But 2 years post-op, the patient complains of left eye blurring of vision since 1 month. She gave a history of uncontrolled diabetes. Patient was using topicals, loteprednol 0.5% eye drops once daily. So the vision had also dropped to 3 by 60. Here we can see under a sclerotic scatter, here we can see endothelial pigments, multiple small endothelial pigments are there. So
diffuse, and their
yes,
KPs or endothelial pigments, which were not noted before. The
Yes,
eye
ma'am.
was almost like you cannot even make out that it was operated in the other picture.
Yes,
But when she came in this, I saw a lot of pigment dispersion, and whether it was KPs, I don't know. But her sudden onset decreased vision was something we should be alarmed.
So the patient was diagnosed to have early graft rejection after DMEC, which is very rare, which is 1%. So the patient was started on prednisolone 1% eye drops 8 times daily, tapered weekly.
So, so one of you summarize and tell all the reasons for graft rejection. One person. Because this is very important. You are doing emergency day in and out, right? You can't just sit there and just give. I've seen prescriptions of given refresh tears for all patients of rejection, sent away and called back in cornea E the next day. That should not happen. After this class, at least it should not happen. Can you please summarize and say all the causes of why these patients develop rejection? You have seen all the cases.
Poor compliance to the treatment, ma'am.
Okay.
Then bilateral keratoplasty done, so
Yes.
the other eye can be an antigenic stimulus. Then vascularization of the cornea.
Yes.
Young age of the patient, ma'am.
Yes.
Then combined surgeries.
Yes. Very good. You did 5.
Associated glaucoma.
Very good. You mentioned young age, compliance, previous surgery,
rejection.
previous surgery, history of trauma in one patient. All right.
Yes.
Aphakia. One patient had aphakia. I still did PK. He was aphakic. He only had 360 vision. It was the only eye of the patient. Aphakia. All these are these are all the risk factors in literature mentioned to be the causative or the reasons for rejection. So remember all this when you see a patient. And loose sutures. You forgot one, loose sutures in the eye. So we showed DSEC rejection, we showed DMEC rejection, we showed full thickness penetrating keratoplasty rejection today.
So,
Quickly now, you
yes,
have to gear 5 now.
Going to the discussion, so corneal graft rejection is defined as a specific immunologically mediated process which may be reversible if detected early or can become irreversible, in which a graft, having been clear for at least 2 weeks, suddenly succumbs to graft edema in conjunction with anterior segment inflammatory signs. So we need to know how to differentiate a graft rejection with a graft failure. Graft failure is absence of graft clarity or persistence of edema within 14 days of surgery, while graft rejection will be clear in the starting. So there's an immune privilege of the eye because of
immune privilege of the cornea.
Yes.
So one more thing. So immune privilege is not for the iris. It's not for. So this the specific thing responds only to the anterior chamber. Immune privilege of the anterior chamber of the eye. So what are the other immunologically privileged sites? Anybody knows?
Brain, testicle, pregnant uterus.
Only in the early phase, yeah. Then that is parts of the uterus, I think. No, I don't know.
Spinal cord, ma'am.
That is
CNS
part of CNS and spleen. There are 4 immunologically privileged sites. It's visible there. It's okay.
So
it's not as interesting as we expected, I guess. Okay, go ahead.
The immune privilege is basically an anatomical barrier which prevents the entry of immune cells. So it is because of absence of blood vessels and the lymphatics in the cornea, because of which the inflammatory cells and the immune cells don't come directly. There's a blood-eye barrier which again prevents the intravascular space coming in contact with the ocular space. The relative paucity of the mature antigen presenting cells in the central cornea, and presence of immunomodulatory factors like TGF-beta, alpha-MSH, VIP, ACAD, which we'll be discussing in the next slide, in aqueous humor, and constitutive expression of CD95 ligand, which is basically for the apoptosis of the cells bearing the lymphocytes basically. So this privilege can be lost because of inflammation and neovascularization.
So those cells which express fast ligand only can have this thing. So fast ligand receptors should be there on the lymphocytes to undergo the apoptosis. Yes. So only certain cytotoxic lymphocytes have fast ligand receptors. So remember that. So the whole thing, immunological prevalence, and the next thing, do you think it's a localized, go to the next thing, do you think it's a localized phenomenon, or is it a central phenomenon?
Ma'am, it's a central phenomenon because even the spleen gets involved, but otherwise this type of phenomenon is not seen anywhere else in the body. And
this is a centralized phenomenon, apparently.
Like,
no, you need to have an intact spleen.
Yes, ma'am.
For this. So
yes,
the entire ACAD and the immune prevalence will not occur if there was no spleen.
Yes, ma'am.
So this doesn't occur only in the eye, like how the definition sounds like associated immune deviation.
Yes.
It sounds as if the eye alone is responsible. No, the immunological tolerance comes from the spleen getting involved. So remember, the central mechanism is the most important thing of ACAD. So now explain what ACAD is.
Yes, ma'am. So ACAD stands for anterior chamber associated immune deviation. It is basically a phenomenon where the eye's anterior chamber induces an immune tolerance to the antigens injected into it. So this suppresses the delayed hypersensitivity response and complement system, but keeps the humoral immunity preserved. So it also adds to the immune privilege of the cornea and preventing the inflammation and the tissue damage that could otherwise impair the vision. How it occurs is basically an antigen enters the anterior chamber and it induces unique immune responses, as we've discussed, and which is different from the typical immune response seen elsewhere. The suppressed delayed hypersensitivity involves the T cells, which is otherwise responsible for the inflammation and tissue damage. The humoral immunity is preserved, so the ACAT still allows the production of antibodies against any antigen, providing some degree of immune protection to the eye, and also primes the cytotoxic T cells.
So that's why those KPs are arising,
Yes,
right?
ma'am.
Because
Yes,
that
ma'am.
humoral immunity
It is
is
causing
responsible for the
inflammation and the-
inflammation. So this delayed hypersensitivity suppression takes place from the sensitized spleen lymphocytes,
Yes, ma'am.
suppression to the CD8
CD8,
cells.
yes, ma'am.
The CD8 gets suppressed here,
Suppressed.
and
CD8 and
CD8 and CD4
Yes,
both
ma'am.
gets
Yes, ma'am.
suppressed in
Yes, ma'am.
ACAD. So
Yes, ma'am.
remember that. If you don't remember anything in ACAD, just remember that there is suppression of delayed
CD4
hypersensitivity. Hypersensitivity.
So the immunology of graft rejection is, graft rejection is the most common cause of corneal transplant failure. There are two types of antigens, major and minor transplant antigens, and the major transplant antigen in the humans are located within the major histocompatibility complex, and individually it is called as an HLA, human leukocyte antigen. So the main mechanism of rejection is delayed type hypersensitivity rather than the cytotoxic T cells, with the reaction targeting the donor minor H antigens rather than the MHC molecules of the donor. So MHC is divided into two categories, class 1 and class 2. And the immunology...
Does class 1 MHC, is it there on endothelium?
Ma'am, no.
No. So MHC, this is a small, MHC 1 is a small, MHC 2 is a larger one.
Yes, ma'am.
So the central cornea lacks MHC
yes,
2,
yes.
but it has MHC 1, the
but
minor
it doesn't
MHC, and it is there up to the stroma. So that is why you can still have rejection in DSEC.
Okay.
The stromal, the more lenticle stroma, the more tissue that you transplant, the more chance of rejection. So you can ask why there is rejection in DSEC, because they still exist. Some of those keratocytes will express MHC type 1.
Type 1, yes, ma'am. So, described by Niederkorn, immunology of graft rejection is as three-legged stool: afferent arm, which is the induction phase, central arm, and an efferent arm, which is the expression phase. So, afferent arm is basically when the host is sensitized to the donor antigens by the means of the APCs. There is a direct pathway which is mediated via the donor APCs, and an indirect pathway.
Tell what APC. I'm sure here at least
presenting
person don't understand what APC is. Even I don't know what APC is.
Antigen presenting cells. The previous.
Tell completely. Don't.
Yes, indirect pathway is mediated via the host antigen presenting cells. So
host means directly, whatever you transplant.
Yes.
So based on this, there was a study, right? Some people removed the epithelium and they transplanted a de-epithelialized corneal graft, and they found out whether rejection is less in de-epithelialized corneal graft. You have that study. The CD, I think in that it is there. So they found no difference in those patients where epithelium was removed. This is when epithelium is there. So it did not matter. Okay, so that is why it is not a major pathway for graft rejection.
Yes, so here we can see as ma'am has told, the direct is because of the donor antigen presenting cells, and the indirect is because of the host antigen presenting cells. So coming to the central arm, which is deviation of the immune response to a state of immune tolerance, where the antigen presenting cells basically stimulates the MHC and in turn causes the CD4 stimulation.
So from there, the antigen presenting cells travel all the way to the spleen and local lymph nodes. There they get suppressed. The delayed hypersensitivity gets suppressed because of spleen involvement. Remember, it doesn't happen only in the eye. So because this is central arm is causing all this clonal depletion, energy, immune deviation is by the spleen and the lymph nodes. Okay, it's not occurring in the eye.
And the efferent arm blockage is because of the protective molecules
this
like
exists within the eye. The fast ligand and what is PDL? Did you?
I forgot.
It's called programmed death leukocyte or something.
Leukocyte type.
Those are there within the cells. Okay, they are responsible for apoptosis of this whatever is causing severe rejection, more
Yes,
edema and all that. Okay,
and apoptosis and causing decompensation.
right. Well, I hope only at least if you remember little bit, go home today itself and read some more, because otherwise this is a very volatile topic in cornea. Okay.
So coming to risk factors, which is high risk keratoplasty. As we've discussed, donor factors can be HLA or ABO compatibility between the donor and the host. It has been shown by the CCTA study that the HLA compatibility is not as important as ABO compatibility. Second point is method and duration of the storage of donor cornea and the nature of the donor button cutting. Pre-treatment of the donor tissue with ultraviolet radiation may reduce the chances of rejection. And storage of corneal tissue may reduce the frequency of allograft rejection.
There was only may, but it was not statistically significant.
Yes, ma'am. Yes,
so
ma'am.
that's why we are not doing all these things.
Yes, ma'am. And also it has been seen that influenza vaccine has increased the chances of rejection, especially seen after COVID vaccine.
Influenza, no. Other than
Even
that,
influenza
COVID.
also and
Recently we
especially
yeah.
Yes, ma'am.
So these are all the causes of thing. What is one thing which we didn't discuss here? Can anybody say? Huh? Sorry?
Simplex.
Herpes simplex keratitis. So we probably didn't get a case which fitted this thing. In herpes simplex viral keratitis, what happens? What is the problem in that eye getting rejection?
Ma'am, there's already immunosuppression and there's reactivation of the infection.
Okay.
And even if the patient is on steroid eye drops, even if the patient is not on acyclovir along with it, we can have rejection.
Yeah, he'll have. But
yes.
What is the problem there?
Like it is causing.
So we do
immunodeficiency.
in herpes in a patient who's had previous episodes of herpes simplex, and we are doing a corneal graft for a
Yes,
scar. If the patient develops rejection, it is very difficult to differentiate from recurrence.
Okay.
So all patients who have rejection in patients with herpes simplex virus are to be considered as reactivation than otherwise.
Okay.
So the entire full dose of antiviral coverage has to be given in rejection
Along
in
with
HSV
steroids.
keratitis along with steroids.
Yes.
So remember that.
Yes.
So in other patients we don't give antiviral cover, antibiotic
Yes,
cover.
yes,
We don't admit the patient and give cefotax, garamycin,
Yes,
gentamicin. All that doesn't happen. But here we have to give
acyclovir,
oral
8
acyclovir.
Yes, ma'am. So, it has been seen suture loosening and
All this you finished. Don't.
So coming to collaborative corneal transplant study, which is CCTS study, it was a multivariate analysis in which 457 participants were taken, and all the participants had at least 2 quadrants of stromal vascularization or a history of previous graft rejection. So it was a high risk penetrating keratoplasty. The patient was followed for 2 to 5 years. And in this, the patient, we could see all the risk factors which we've discussed before. The young recipient age, the number of previous grafts, history of previous anterior segment surgery, preoperative glaucoma, quadrants of anterior synechiae, stromal vessels, and history of chemical burn or a blood group ABO incompatibility were among the strongest risk factors. And there was no significant improvement in the graft survival who received HLA matched corneas. So hence routine histocompatibility testing for these patients is not justified. So coming to each and every factor, vascularized cornea is basically defined as the number of quadrants of vascularization rather than the total number of blood vessels. The CCTA study defined high risk as cornea with more than 2 quadrants of deep stromal vascularization, and the risk of rejection is doubled.
It's 6 o'clock. If anybody has any duties to go to ward or anything, please leave. It's a little long class. If anybody has any duties, you please can go. Has anything emergency, I would not mind. You may leave. No? Gym, anything? Nothing?
Specific 1.7 times. And Algrid and Kashmir found a 14% frequency of endothelial rejection in corneas with little or no preoperative vascularization compared to 32%
What is the importance is? How many degrees of vascularization is important for us?
Yes, ma'am.
How many?
Ma'am, more than 2.
More than 2 is defined as high risk.
keratoplasty.
So that is the motto of this particular graft. That anybody who's had more than 2 quadrants of deep vessels, you have to write in the file high risk graft. Some other files I write high risk graft. So unless I write high risk graft, I won't be starting all those
Orals.
medications post-operatively.
Prior graft loss rejection rates in comparably vascularized recipient beds showed 40% rejection after the first graft, 68 after the second, and 80% after the third graft.
So this is important because when you counsel a patient for graft, you will tell them every graft that I do, there are more chances of you losing the eye,
Yes.
the cornea. So you will have to give the patient a realistic idea, because sometimes one graft would have lasted 10 years and the second graft won't last even up to 1 year. This is the very reason that there is every time that you do a graft, the outcomes are getting halved.
Yes. CCTS study showed with every subsequent graft, the increased chances of rejection is by 1.2 times. So why does it happen is residual of the previous surgery is there, which could be in the form of vascularization or peripheral anterior synechiae, and also immune pre-sensitization is there. So the antigens of the donor and the recipient are shared, and so your afferent arm is circumvented. So increased corneal graft diameters is a risk factor because it is closer to the limbal vasculature and also contains more antigenic materials. And as we've discussed, the peripheral cornea has more lymphocytes. The Koda-Dost and Silverstein found that the eccentric lamellar grafts in rabbits were otherwise stimulating the rejection more effectively than the central grafts. So this distribution can be hampered by prior inflammation or any surgery. In anterior synechiae, if it is a peripheral anterior synechiae involving 3 to 4 quadrants, a direct contact with the host vascular system can be there with the increased risk of failure. If there is an anterior synechiae, chronic inflammation or previous anterior segment surgery can be there causing the anterior synechiae. The CCTS study showed that the failure rate doubles in the eye with 3 to 4 quadrants of anterior synechiae. Other non-immunologic factors are increased incidence of glaucoma, synechiae, and because of this, it causes traction on the corneal endothelium and causes an endothelial cell loss.
You mean synechiae causes traction,
Synechiae
not glaucoma? No? When I was reading your slides, I was wondering, why does glaucoma cause traction on the endothelium? Okay, now I understood.
And if there is a history of anterior segment inflammation, it causes the afferent arm and the efferent arm to be stimulated, causing again vascularization, lymphatic stimulation, and cytokine release. Ocular surface diseases, CCTS study showed chemical injuries have a 3.5 times the risk compared to the other high-risk keratoplasties. So the patient presents to us with symptoms of redness, pain, photophobia, blurring of vision, and irritation. And there have been studies which have showed that the 70% of the graft rejections were identified by the patient's symptoms and 30% by the physical examination by clinicians.
What does this sentence mean?
So hence we need to ask for detailed history from the patient, along with if they had a non-compliance.
So every time a patient comes, you need to rule out whether there was an episode of
redness
rejection.
Yes.
Because then you have to hike up the steroids.
Yes,
because some of them are not everybody is going to be as vocal or clear in their thoughts and to tell us what happened.
Yes. And series were also there which found that DSEC patients with graft rejection presented with no symptoms. So the signs which we've seen already are conjunctival flushing. There is subepithelial cellular infiltrates which we saw in our subepithelial rejection are called as Krashmer spots. Then there's epithelial rejection line. Then this inferior line which is coming from the periphery is the endothelial rejection line, and conjunctival vascularization. So this is the table summarizing the different types of rejection. The epithelial rejection being the least common and followed by the subepithelial rejection. The most common is endothelial rejection of 2 to 44%, more common in young individuals. And generally the patients with epithelial rejection are quiet, asymptomatic, while the patients with endothelial rejection will have pain, redness, and decreased vision. And the signs which we've discussed it is the epithelial rejection line, which is an undulated, elevated line. And subepithelial rejection will have the subepithelial infiltrates. or
all
neovascularization.
mentioned. So
yes, ma'am.
there is one rejection which is hyperacute stromal,
Yes, ma'am.
which we
That-
typically see in a way when we operate on a hotbed like a therapeutic penetrating keratoplasty. The patient will come suddenly with whitening of the graft with cellular infiltration, but there will be no hyperpion. So and when you scrape, there will be nothing in the no organisms will be there except for some epithelial cells and thing. So this sudden whitening of a previously edematous graft with symptomatic thing looks like rejection, but is not rejection. It's very few people actually can point out that it's a hyperacute rejection. It's usually seen post therapeutic keratoplasty. Okay, go ahead. All this
Yes, ma'am.
you have explained.
So all these
beautifully.
signs also we've seen, and it is the epithelial rejection line is staining with fluorescein and rose Bengal. Stromal rejection can have a stromal necrosis in case of severe rejection.
Everybody will dream of
Yes.
your rejection if you say
And,
more. You go back to the previous slide. This is important.
Yes.
Yeah, this.
So this is grading based on the signs we see. A possible graft rejection can be there if previously clear graft was there with graft edema, but no inflammation, no rejection.
This reference that you have quoted, this is actually being, you should quote survey article by Anita Panda.
Okay.
In 2007 or 8, they have published this.
Okay. Yes,
that
ma'am, it
corneal
was-
graft rejection in survey. You should
Okay.
take proper
Yes, ma'am, this
reference. Stat pearls and all are not to be quoted.
Okay.
This is not there in stat pearls. They have taken from survey article.
Okay.
Okay, Panda et al.
And the probable graft rejection will be when previously clear graft along with AC reaction, keratic precipitates, graft edema, but there's no rejection line. And definite is when we have an endothelial rejection line along with the other factors. So as we've seen in our cases, can graft rejection occur in lamellar graft? Yes. Stromal and epithelial graft rejection in DALC is 1 to 24%, while in endothelial rejection is there in DSEC of 0 to 45% and DMEC of 1%. So how can we prevent rejection? Preoperatively, measures to minimize the antigenic difference between the host and the donor tissue needs to be taken, which is ABO matching. Intraoperative factors of meticulous surgical technique, including avoiding the decentration of the recipient bed trephination and optimal suturing with good graft-host apposition. Post-operatively, we need to control the host immune response by giving steroids. So need for optimal post-operative care and close follow-up is very important for timely interventions in terms of suture management, and this results in early detection of the rejection and management. So management is basically corticosteroids as the gold standard, and they can be given in form of topical or systemic. In cases of epithelial and subepithelial,
Not topical or systemic. Topical and systemic.
Okay, ma'am,
If you
for
say topical or systemic.
Ma'am, for epithelial also we give oral?
No, that
Yes,
is why I'm
ma'am,
saying
yes.
topical and systemic.
Oh,
So if you said or means, will you give systemic for epithelial? No.
Yes. So for epithelial and subepithelial rejection, topical steroids 6 times daily, tapered over 6 to 8 weeks
It's
is
always
given.
hourly. Maybe we gave less. Pulse dose of high potent steroids should be started in emergency or as quickly as possible. Say it's pulse high dose steroid. So high potent steroids. Remember that word.
prednisone, yes,
So if you say frequent steroids, with the examiner will ask, so shall I give loteprednol? So you have to understand. You should cut them short and say
High.
pulse high dose high potent.
steroids.
So that is the word to be used in all rejection. Pulse high potent steroids will be started immediately.
Okay. And in cases of severe endothelial rejection, along with the topical steroid drops, we can give oral pulse therapy of IV methyl.
We can give, no. We have to give.
Pulse therapy of IV methyl prednisolone, 500 mg.
So why
for
have
3
you
days.
written 3 days? Where is it written?
Ma'am, it is given in the paper also. It was given for 3 days and...
So this is a proper... this IGO article mentions 3
Yes,
days.
yes, ma'am.
So as a but that is an ONTT trial. We are not treating optic neuritis.
Okay.
So IV methyl prednisolone, one single dose only.
Okay.
One single dose, 500 milligram is status-stat. You don't have to immunosuppress the patient so much.
Yes,
Okay, we will go through that again, but if you tell the examiner 1 to 3 days, that will be a safe response. But as such, it is given only once, not 3. Only in ONTT trial, it's given 3 days. This is not ONTT.
Followed by oral steroids, starting from 60 to 80 mg per day and tapering weekly.
You don't say 60 to
Based on
80.
weight.
It is called full dose steroid, which is 1 milligram per kg body weight.
Yes.
That is how you mention the dosages. You don't say 60 to 80. If the patient is more than that, then you are giving less. So always say milligram. Go ahead, fast.
And these are the cytotoxic agents.
That's all. You just mentioned the name: azathioprine, cyclosporine, mycophenolate. Mycophenolate is the most common now because it has less side effect. Tacrolimus, we don't give parenteral, we give topical, but they have found that both topical cyclosporine and tacrolimus have not reduced or delayed the rejection. But do read about azathioprine, which was given before mycophenolate. Yeah, go ahead.
And this is the recent most treatment algorithm for different types of keratoplasties. In DMEC, we'll give prednisolone 1% gradually tapered for 6 months, followed by loteprednolol or fluorometholone once a day for 1 year. And if we have a rejection, we'll again put the patient on prednisolone, otherwise continue loteprednolol. Similar for DSEC. For DALT, we can have a low risk or a high risk, in which low risk is as given as DSEC, prednisolone followed by loteprednolol. But in cases of high risk, subconjunctival dexamethasone or methylprednisolone 40 mg per milliliter.
So this is not being followed, right? So why we don't follow this? Why do we don't want to touch the eye? Neither do we want to cause an acute spike in the intraocular pressure. Because if you give subconjunctivally, there is an immediate diffusion by the lymphatics and the conjunctiva into the anterior chamber also. Okay, so we don't do this. So we give, look at this, you have to give 1 hourly prednisolone. Probably very few people give subconjunctival. We probably don't do. For PK, again, bevacizumab is written.
Yes.
They have again found out that the role of bevacizumab is very anecdotal.
Yes,
This literature that you are quoting is not from the Cochrane meta-analysis. So if the same thing was published in Cochrane meta-analysis, that will be the gold standard.
Okay.
So this is not a meta-analysis paper. This is what you are mentioning is only a literature review. It is not a considerate high value to this. So here they will just mention from all the things what is in, but in the gold standard remains topical steroids. Within 3 days, if endothelial rejection comes, IV methylprednisolone. That's all. If you don't remember anything, forget all this bevacizumab subconjunctivally. Steroids, IV methylprednisolone. Certain centers give oral steroids, certain centers don't give, but the dose of oral steroids. Then write about steroid sparing agents to be started along with steroids, because they take 4 to 8 weeks to start, especially in high risk grafts. Steroid sparing agents are started because oral steroids cannot be a lifelong therapy because of causing glaucoma and cataract. So just remember concisely like this and write your answer. Just go ahead. I think that's all. Okay. Thank you. Thank you so much.
Thank you, ma'am. Thank you, everyone.